I'd like to talk today about hepatitis C. This is a very fast-moving disease as far as how we evaluate it and treat it. And so there really aren't guidelines for it. If you come across a patient with hepatitis C, I would recommend going to the AASLD website, and they have current recommendations which they are updating every year. Now, I will start with screening by risk factor is not adequate, and there are certainly recommendations now to screen everybody over the age of 18. Those recommendations are probably going to change because the demographics of the disease are rapidly changing, in part due to the opioid crisis and to the large amount of babies now exposed to perinatal hepatitis C. So hepatitis C in babies. There are a couple ways to screen. You can wait till after 18 months of age and screen for hepatitis C antibody. There are some worries about babies being lost to follow-up, and there are also concerns that parents really don't want to wait till their child is 18 months old to see if they're infected, because there's about a 5% transmission rate if you don't have HIV. So you can check RNA. You should not check it before 2 months of age because the level may be too low. And if it is positive, you can then wait till 3 years of age to see if it's still positive. Some babies who are infected will clear the virus on their own. The other thing that I wanted to say about antibody testing, and we don't use antibody testing less than 18 months of age because you get mom's transplacental antibodies, but sometimes you can get a false positive antibody. But if you check another platform, it is rare that you would have it falsely positive with 2 different assays. Usually you want to confirm that you're actually infected, not just having been exposed to it, so you would get an RNA to confirm it anyway. We now have excellent and well-tolerated therapy for hepatitis C. The therapy is exceedingly well tolerated and usually only 2 to 3 months in duration. It's oral, and we are really trying to catch up and get everybody treated. It is fairly expensive, so at first it was rationed, but it's been shown to be cost effective to treat someone earlier so that they don't develop complications of liver disease, which are very costly to treat. You should check genotype because there are some pan-genotype therapies, but I have never had a payer who will approve a therapy without knowing what the genotype is, and some therapies only work for certain genotypes. You also should evaluate for the extent of fibrosis because that may change how long you treat for. You can use elastography and don't necessarily need a liver biopsy for this. Elastography can be done with MR or ultrasound technology. Other things that you need to know about treatment is that the therapy often interacts with diabetes therapy and warfarin therapy. You should also be careful to avoid hepatotoxic drugs and nephrotoxic drugs if you are treating, and to screen for hepatitis B, because just getting rid of the hepatitis C can activate hepatitis B. So you need to know ahead of time if the patient is also infected with Hep B. I wanted to talk a little bit about pediatric hepatitis C. Fortunately, it usually progresses slowly, although we can have some kids who progress quickly. It's not clear if this is just because they don't partake of some of the other things that speed up fibrosis, like alcohol and other drugs, but probably has to do with also how the virus interacts with the immune system. We now have therapy approved down to age 3. You have to remember to vaccinate for both hepatitis A and B, because you don't want them to get another viral infection of the liver. And if they do have cirrhosis, they can get hepatocellular carcinoma. You should be talking to them about hepatotoxic drugs and alcohol. And because therapy is good, we do not recommend delaying organ transplantation or bone marrow transplant because of hepatitis C. We just treat simultaneously. I want to talk a little bit about acute hepatitis C. Usually you can detect RNA within 2 to 3 weeks of exposure. The antibody comes much later. So if you're worried about acute hep C, the antibody is not the test to order. About a quarter of the patients will have jaundice, and acute liver failure is very uncommon. During acute hep C, you have a very high viral load, so it does increase your risk of transmission. This is an algorithm which talks about what to do if you have a known exposure to hep C. Unfortunately, most of the time we don't know when the exposure is. And it basically says you need to first screen to see if they're already infected, and then to follow them over the next 6 months to make sure that they didn't develop hepatitis C. The question also comes up about what do you do if you have an organ donor that is hepatitis C. In general, we have not used these organs, but due to the opioid crisis, we have more and more organs available that are infected with hepatitis C, and sometimes these organs are used to increase the donor pool. You do need to get consent, and you need to treat with pan-genotype therapy starting in the first week and for at least 8 weeks. The data is still small, but it looks like if properly treated, this may be a way to expand our donor pool. And that's just a quick view through hepatitis C.